No, no, for us, okay.
So I'll be back in 5 minutes.
Yeah. Yes, sir.
আমরা কি লাইভ আছি এখন?
Good evening, Dr. Jaideep.
Good evening, sir. Thanks for joining.
Yes, I was ready. I was waiting for your order.
No, sir. Good evening, sir.
Yes, Dr. Bhaskar, good evening.
Good evening, sir. Good evening. How are you, sir?
That's fine.
I'll come back, sir. 2 minutes.
Yeah.
Dr. Jaideep. Good evening, sir. Thanks for joining.
Yes, I was ready. I was waiting for your order.
Good evening, sir.
Yes, Dr. Bhaskar, good evening.
Good evening.
Jaideep, how that
Yes,
that
I am
conversation?
also wondering. Somnath, why there is an echo?
ঠিক আছে
Why there
ইউটিউব
was echo?
এটা মার্জ হয়ে গেছিল যার জন্য ইকো হচ্ছিল
Okay.
এখন ক্লিয়ার হয়ে গেছে
Dr. Prajapati, Dr. Tushar Shah has wished you happy birthday.
Yeah, thank you very much, friends.
One day late, but still, we all wish you happy birthday.
Very nice of you.
Sir, physically, webically, today wishing, sir.
Yes.
Webically.
Somnatha, are we live? I think we are live now.
ইয়েস
Okay. You can show that program also. Till
Okay.
we are live.
ওকে
Huh?
ওকে ওকে
I will give the introduction. Then only I'll tell you to stop sharing. Then you stop sharing.
ওকে
So, Dr. Prajapati, it's 7 and we have a sizable number of attendees both in the Zoom platform and also in the YouTube link. So after a brief introduction, I will request you to start. Good evening, everybody. Thanks for joining us. 12th November happens to be the World Pneumonia Day. And we as pediatricians and especially interested in infectious disease feel it's an obligation on our part to discuss about pneumonia on the eve of World Pneumonia Day and cultivate the knowledge and share what we have come to know of diagnosis, management, and prevention of pneumonia. As you are well aware, both in the numerical counts and in the percentage wise, India is the largest contributor of under 5 mortality in the world and highest contributor of deaths due to pneumonia and deaths due to pneumococcal disease in the world. It's time that we discuss some aspects of pneumonia, make us aware, share knowledge, and pass it on to the patients and parents for general awareness. World Health Organization has selected 12th November as the World Pneumonia Day, and we on behalf of Infectious Disease Chapter of IP try to organize some event on this occasion. This evening, we have selected some very interesting topics. To start with, it will be radiology in pneumonia. Dr. Baldev Prajapati, senior consultant pediatrician from Ahmedabad. He is a teacher. He takes regular classes in DIP platform, also a past chairperson of IIP Infectious Disease Chapter. Everybody knows him. So we will start with Dr. Baldev Prajapati on radiology of pneumonia, followed by Dr. Bhaskar Shenoy, who is the executive editor of Pediatric Infectious Diseases Journal. And a huge congratulations to this person and also Dr. Vijay Yele for indexing this journal. He is from Bangalore, from Manipal Hospital, and he's a learned faculty. He will discuss on treatment of pneumonia. Followed by infectious disease specialist from Mumbai, Dr. Tanu Singhal, will deliberate on complicated pneumonia. Yours truly will offer some other aspects, some conditions which might mimic pneumonia. And as the icing on the cake, the floor will be all to Dr. Vijay Yele, past president of Indian Academy of Pediatrics, past chairperson of IIP Infectious Diseases Chapter, editor-in-chief of Pediatric Infectious Diseases Journal, to discuss some aspects of prevention of pneumonia with 3 eminent faculty members, Dr. A.J. Chitkara from Delhi, Dr. S. Balasubramanian from Chennai, and Dr. Pallav Chatterjee from Kolkata. So we expect that this will be a very interesting and very informative discussion on the occasion of World Pneumonia Day, with our motto of stop pneumonia, every breath counts. We are grateful to Pfizer for the academic support that they has given to this program. So may I request Mr. Somnath to stop the screen sharing, and the floor for the next 20 minutes is for Dr. Baldev Prajapati. So please start sharing, Dr. Prajapati, sir.
Yes. My slides are seen properly.
Sir, make it full screen, please.
Dr. Chaitya.
Make it please full screen.
It is full.
Ah, yeah, then it's fine. Now
It is
it's
full
fine.
screen.
Now it's fine.
And I am audible also.
Yes, sir. Perfect.
Okay, thank you. Good evening, friends. As already Dr. Jaideep spoke on the part of introduction, organization of the CME on pneumonia by the ID chapter on the occasion of World Pneumonia Day is quite relevant. And I would like to express a word of gratitude to the office bearers for giving me this opportunity to be part of this CME. And the topic assigned to me is radiology in pneumonia. Friends, all of you know, as already even Dr. Jaideep said, that pneumonia in the children is a significant cause for the morbidity and mortality, especially under 5. And still we don't have the gold standard specific diagnostic test, and we are trying with the different modalities, either clinical, microbiological, or radiological, and even others. I think, friends, all of you are familiar with this WHO clinical case definition of pneumonia. They have selected some signs and symptoms that cough, cold, tachypnea, chest in drawing, with that some danger signs or some severe respiratory signs like grunting, stridor, cyanosis. They try to classify that no pneumonia, pneumonia, severe pneumonia, very severe pneumonia. And WHO said that pneumonia is a clinical diagnosis. Friends, you know that for this workup, around 1980, some academic centers tried to define some signs and symptoms very specific for diagnosis and to define the severity of the pneumonia. Based on that study of the various centers, WHO prepared the guidelines in 1990 for healthcare workers. So that diagnosis of the pneumonia should be very easy. On that ground, when to start the antibiotics, that can be guided. And even with the severe pneumonia and very severe pneumonia, timely reference to the centers with the facility, so that under 5 mortality can be brought down. That was the idea. And we learned that yes, tachypnea is the most sensitive marker of the pneumonia. But we learned that yes, it is highly sensitive, but lacking the specificity. And ultimately, even it resulted in the overuse of the antibiotics. And somehow we came to the conclusion after this long experience that still we don't have the standard clinical definition for the pneumonia. This is fairly good. Definitely to some extent it has helped to bring down this under 5 mortality, but still we don't have the standard clinical definition. Microbiologically, if we see the investigations, we know that culture positive is the gold standard. But here in the case of pneumonia, with the base setup, the positivity comes to 5 to 30%, and average usually 10 to 15% only. So that is not satisfactory. Molecular techniques which are very highly sensitive, but regarding whatever the results are there, difficult to say that this is an etiological agent. The reason we know that the specimen collection influences the results. And in pneumonia, collection of the sample is very difficult. If we go that the lower airway specimens are most ideal, that is in the needle lung aspirates, but all of us know that it's not visible. So again, probably due to microbiology also, we are not able to do the much. And friends, you will agree with me that having all these points, since long probably chest X-ray, for the practical purpose is considered the gold standard for diagnosis of pneumonia. And other modalities, ultrasound, CT, MRI, to some extent, they have also their role. Let me discuss that how the radiology helps for the diagnosis and further management of the pneumonia. Friends, all of us know that very frequently we are discussing that chest X-ray is not routinely indicated for diagnosis of pneumonia. Yes, to some extent it's right, but very specific indications we have to keep in mind. The suspected or documented hypoxemia, significant respiratory distress, failed initial antibiotic therapy, suspected complications in a case of pneumonia, or wheezing which we have considered with this viral origin or something, but when the patient is end up with this fever, hypoxemia and severe disease, we have to go for the chest X-ray. And many times the question comes that what are the indications for repeat chest X-ray? Failure to demonstrate the clinical improvement in 40 to 72 hours, definitely we should go. That will probably give the idea regarding the complications of pneumonia. Or when you are considering the recurrent pneumonia, you know that this documentation of radiological clearance is very important for definition of recurrent pneumonia. So here we'll have to go for the repeat chest X-ray. Or when you are suspecting some anatomical malformation, some chest mass, foreign body aspiration, yes, here we have to go for the repeat chest X-ray. So I think these are the very clear-cut indications for the chest X-ray and for the repeat chest X-ray. Having this, let us check that what are the radiological features of pneumonia. I think this is our daily office practice. We are going for the chest X-ray. And I'm sure that if you are aware, it helps us a lot for its interpretation. We know that abnormal lung opacity, air bronchogram lines, seriato sign is very important. And we know that seriato sign, meaning thereby loss of clarity of the diaphragms and the heart borders. Many times I think this part is ignored by us, or probably we are not aware of it. Or the increasing the size and number of the lung markings, opacification of the lung behind the heart saddle, or below the diaphragm, again, very easily missed by us in the practice. Or in the spine side, very, I would say, learned radiologists point out that loss of normal darkening inferiorly of the thoracic vertebral bodies on the lateral view. And probably that suggests the lower lobe infections. So I'm sure that if you're aware, you can check that is there any of the point which will help you to say that radiologically to define the pneumonia. Having this, let me take to some of the practical aspects. This 6-year-old girl presented with a high-grade fever of 5 days and cough, leukocytosis, polymorphonuclear reaction, and this was the chest X-ray. And I'm sure that this chest X-ray, if you go in the details, yes, it is the right zone opacity with the air bronchogram. And with this, it is very clear-cut diagnosis without any hesitation that yes, it is the right upper zone pneumonia. Let me make the point here that what we mean by the air bronchogram. We know that what we mean by the pneumonia. Pneumonia is the inflammation of these lung parenchymal tissues, alveoli. And there is the collection of the exudate. And therefore, due to the collection of the exudate, normally the lung parenchymal tissues alveoli contain the air, which is replaced by the exudate, which gives this whitish opacity. But particularly the bronchi or the airway, it contains the air. And therefore, these type of the airways or darkening of the lines in this opacity is called the air bronchograms, and that is very classical, I will say, picture of this pneumonia. It can be seen in other conditions like hyaline membrane disease, pulmonary edema, that we can keep in mind. But please, friend, remember that in a case of pleural effusion or solid mass, this air bronchogram will not be seen, and that you can differentiate even the white opacity, whether it is pneumonia or due to some other condition. Let me show you this most of the X-ray pictures I selected from my own patients. And this was a patient 8-9 months old after a few days of the measles. And the child was very bad, toxemia, distension of abdomen, high-grade fever. And you can see this chest X-ray. This paratracheal opacity with this destruction, and even here also. After a few hours, we can see that the radiological picture, and I remember this X-ray was taken just after a few hours, 4 to 6 hours. And even if I take to the third X-ray picture of the same patient, changing, and after 8 to 10 days of antibiotic therapy, we can see the normal X-ray picture. But actually, I want to bring to your notice that so fast changing radiological picture is a very characteristic of Staphylococcal or any virulent organism. Specifically, I will say this is more so commonly in the practice in the Staphylococcal. Even this type of the lung abscess, having this pneumonia, then resulting in the necrosis and collection. I think Dr. Tanusinghal will go more in the details, but just to show you, and later on we know that even resulting in the pneumocystis formation. I think these are not uncommon pictures in our daily practice. Friends, what I wanted to show you, and what are the radiological characteristics of the staph pneumonia? We know it is common in the infants and young children, commonly associated with the measles, skin infections, cystic fibrosis, occasionally, rarely, hyperimmunoglobulin E or the Job syndrome. Very characteristic, rapid changing radiological picture. I think that should make you alert. And once it results in the necrotizing pneumonia, in the pneumocystis formation, in the lung abscess formation, I think that very sharply indicating it is a staph problem. And all of us know that now the community acquired MRSA is increasing with these problems and complications, and it requires very specific attention. I will take you some other pictures also, and I'm sure that probably that gallery of the picture will help us a lot. Very specifically opacity, but you know that the bulging of this transverse line, fissure side, what we say. And it is said that this is very classically seen in a case of the Klebsiella pneumonia. This is called the bulging of the fissure. It is said that if it is the bulging, that is showing this bulging is the characteristic of the pneumonia. But suppose the fissure is going up, this type of some line, that indicates the collapse. So I think that also can differentiate it from the fissure side. Friends, I think now the Mycoplasma pneumonia is also not uncommon. And how it presents, we know different radiological pictures are known, maybe in the form of unilateral lower lobe involvement, even the starts from the hilum and later on fading out is a characteristic of the Mycoplasma. But now it is said that the Mycoplasma is known for complications like necrotizing pneumonia and even the empyema also. That we should keep in mind. Friends, this is very classical, I will say, just picture of the pneumocystic girovese or the pneumocystis carini. It is bilateral, symmetrical, diffuse, fine to medium reticular opacity. So basically, it is an interstitial involvement, or maybe seen from the multiple nodules and the nematocells. And I'm sure that this pneumocystis carini, which is more associated with the HIV, is not uncommon in our practice. This fungal pneumonia is not so common, but particularly in immunocompromised children, and particularly the preterm babies. Widespread bilateral interstitial fluffy alveolar infiltrates is seen with the even HIV and malignant conditions, those who are immunologically compromised. Then just to show you, we are familiar with these different tuberculous pictures, pneumonia, paratracheal, even the pneumonia or the glands, or even biliaries, even the reactivation type of tuberculosis where you will see the destruction of the lung tissues and even the cavity formations. So I'm sure that this to be differentiated from other organisms, and tuberculosis can also give this type to different type of radiological pictures, which we'll have to go for differential diagnosis in our daily practice. Let me take you through some of the viral pneumonias. And I think this part is very difficult in our daily practice. Viral pneumonia occasionally may come with this type of picture. We may even consider it a collapse. But you know, this is a picture after, I think, a day or two only. That means this was maybe the collapse due to the mucous plug formation. And with the treatment, probably it has cleared. And very nicely, ultimately, the picture of the pneumonia is seen. And this is saying that this type of the mimicking atelectasis is not uncommon in viral pneumonia. At the same time, these are the interstitial pneumonia, that is diffuse haziness of the lung. In the right lower version, you can see left lower version also. And some reticulation of the lung bases is very common in the viral pneumonia. Occasionally, when it may happen so that this type of even with some consolidation like picture, what we see with the alveolar infiltration is also seen in a case of viral pneumonia. There is some viral different types of pictures which we can keep in mind. Here, I think in this patient, if you see that this is a cellular sign, what is actually cellular sign? The clarity of this cardiac borders and the diaphragmatic borders is blurred, and that indicates that some other shadow is contributing for blurring of these pictures. And that is here, if you see that this particularly right border of the heart is blurred, but if you take the lateral plate, very nicely it shows the opacity. So I think whenever you have a doubt, please without any hesitation go for the lateral plate. I think this type of the cytology is not uncommon in a daily practice. That the left cardiac border somehow it is lost, and that if you go in the lateral plate shows that the left diaphragmatic cellular sign. Similarly, this is even the right diaphragmatic sign is also seen. This is just to show the different pictures. At the same time, even this type of the left cardiac border, somehow this is not we are able to trace, and even behind this left hilum, we are able to see something. That is the dense and the large. And friends, if you go in a lateral plate, this type of the pneumonic consolidation can be picked up very easily, and we can clear this our confusion. Friends, by this picture, what I wanted to share with you, and what are the various radiological pictures of the viral pneumonia which we can keep in mind. It can be alveolar pneumonitis in the form of the nodular, fluffy, patchy, or even the consolidative. Segmental atelectasis due to the mucus plug formation, which I showed you the first picture of the viral. Peribronchial infiltrates, accentuation of the parahilar density, and even the interstitial pneumonitis, which may be the sticky or reticular infiltrations. So I think these are the different points which we can keep in mind. We cannot forget this COVID-19 pneumonia, which recently we have learned. And we know that here, which may have some doubt, within a very short time, it is bilateral, and with the ground glass opacity, and even on treatment, sometimes it gives a good results also. I think this is something new, but that also probably we will learn more in the COVID-19 pneumonia. Aspiration pneumonia is not uncommon in the pediatric practice. And I think these two varieties we have to keep in mind. One is the hydrocarbon pneumonia following the kerosene ingestion. Somehow now the incidents are decreasing compared to our past days of residency, but still it is there. And that can be this type of the bilateral picture. And we know that still the tradition of instilling oil in the nostril, this aspiration resulting in the lipid pneumonia, bilateral, these type of opacities. And clinically, child is very bad. And in spite of, I would say, long duration of the treatment, it takes more time for the radiological clearance and even for the clinical response. So these are the aspiration pneumonias which are common in the practice, which we have to keep in mind. Friends, what we learned from this discussion of this chest X-ray in the various situations of pneumonia, that okay, chest X-ray is good, but somehow it is not enough. We don't have the correct sharp answer. Fairly good help is there. So I think still we are not satisfied. If I mention regarding this newer modality, I think few years back, I remember in this respiratory chapter, that was a big discussion for, I would say, long, even the panel. And that the chest ultrasound, they said it's a fast, non-ionizing feasible technique. But here you please remember that the ultrasound is having the high negative predictive value. Therefore, suppose sonographically, there is no pneumonia, I think that almost excludes the possibility of pneumonia. I think that we have to keep in mind. Somehow it was said during that time that this ultrasound may replace the X-ray. to exclude the lung consolidation in the children. I remember that a few years back, this discussion was there, and even the several articles in the publications, somehow it has not exactly translated into practice. We do not know exactly the status and how much utility in our practice that we'll have to see in the time. Friends, routinely CT scan is not indicated for the pneumonia. But yes, in the complications, and I'm sure that Dr. Tanu Singhal will go into more details, that necrotizing pneumonia, lung abscess, CT scan is very helpful modality for further evaluation and even the plan of the management. Despite the potential advantages, there are limited studies that have investigated for the role of MRI in the pediatric pneumonia. We don't have the correct picture that how much MRI is useful for these pneumonia as per these recent references. Friends, these are the differential diagnosis. I think my friend Dr. Jaideep will go in the details. That the thymus can be mimicking like pneumonia, atelectasis, effusion, congenital pulmonary malformations, some GI malformations, even sarcoidosis like granulomatous disease, collagen disease. Some secondaries can also mimic like this pneumonia. We'll have to go into the details. And I'm sure that this is going to be covered very nicely by Dr. Jaideep. We'll see the details with that session. Friends, what I wanted to convey in this 20 minutes time, that in spite of the significant mortality and morbidity due to the pediatric pneumonia, we don't have the gold standard for its diagnosis. WHO clinical case definition of pneumonia is definitely sensitive, but not that specific. Microbiological investigations have either some limitations or not feasible. Chest X-ray somehow, practical purpose is considered the gold standard for the diagnosis. But chest X-ray is not routinely indicated. Indications for the chest X-ray and repeat chest X-ray are going to be discussed and best ways to follow it. For friends, what we learned from this discussion, that interpretation of the chest X-ray should be by clinician rather than the radiologist. And I'm sure that all of us have learned that pediatrician can have the better interpretation of the chest X-ray, and it is more crucial that we have to learn. Yes, USG may replace the chest X-ray to exclude the diagnosis of pneumonia in children. Let us see with more reports. CT scan may be useful for complicated pneumonia like necrotizing pneumonia and lung abscess. Role of MRI in the pediatric pneumonia, we are not sure. I think these are the points which I wanted to bring to your notice. And once again, thank you very much. And I should express a word of gratitude to the office bearers for giving me this opportunity. Thank you, friends. Thanks a lot.
Thank you, Dr. Prajapati. It was absolute pleasure, a comprehensive talk on radiological diagnosis of pneumonia. Thank you very much. Please stay. If you have any question, we will take up later.
Sure.
Now, when diagnosis is there, can treatment be far behind? We have Dr. Bhaskar Shenoy from Bangalore, and he will discuss for the next 20 minutes on treatment of pneumonia. So the floor is yours, Dr. Bhaskar, please.
Thank you, Dr. Jaideep, for the opportunity given. I think after Dr. Baladev's excellent lecture, I think we don't have anything to say. But once a diagnosis is done, as you told rightly, that we have to go for treatment. So how do we plan the treatment? As we know that community-acquired pneumonia, you have told in the introductory part that it is responsible for a great number of deaths. Viruses are more common, and Streptococcus pneumonia is the commonest bacteria, followed by Mycoplasma, depending on the age group and depending on the clinical period. So how pneumonia is classified? So why this classification is important when I am talking about treatment? Because the treatment options, treatment modalities depend on the type of pneumonia, whether it is infectious or non-infectious, and how is the radiological findings, then whether it is a simple or complicated pneumonia. Is it a community acquired or a hospital acquired pneumonia? And according to WHO, is it a severe pneumonia or just pneumonia? So having said that, to start the treatment, we should recognize and we should stratify the pneumonias. So recognition, the clinical criteria, I'll not go into the details, just what we do in clinical practice is the fever, cough, tachypnea. Then if there is a respiratory distress, consolidation signs, older children may come with chest pain, signs of hypoxemia. It is one of the most important things. We need to monitor the oxygen saturation of all these patients. So we all know that there is no single symptom or sign which is specific for pneumonia. WHO has classified in children between 2 months to 59 months with cough and difficulty in breathing. We need to stratify them into various categories. If the child is having only cough and cold, it is no pneumonia. Fast breathing and chest indrawing, pneumonia. General danger signs in the sense child is not able to drink, child has a persistent vomiting, child is comatose or unconscious, lethargic, having convulsions, or child who is in SAM, severe malnutrition. And these are the patients where the severe pneumonia is there. Symptoms are there, that goes into severe categories. And this is mainly for the community health workers in the fields. So once you do the, confirm the diagnosis, suspect pneumonia, we need to confirm the pneumonia, because this triangle should be followed in every case to start the treatment. First thing is to confirm the pneumonia. Am I dealing with pneumonia? And you try to see the severity of pneumonia, because that needs intensive care, oxygen, and other resuscitative measures. Then we need to look at the etiology, because your initial treatment options depend on the suspected etiology of the pneumonia. So there are many guidelines, IDSA, that is Infectious Disease Society of America, and British Thoracic Society guidelines. That IDSA guidelines take care of both adults and children. But this is one guideline, though it is little older, and this is focused on children. We don't have proper guidelines in the recent past by the major societies across the world. So coming to the antibiotic management, the questions should be asked is whether to treat with the antibiotics. But of course, in a pneumonia, which is very difficult to have a etiological diagnosis, we need to start a treatment in most of the cases. Then antibiotics, if it is so, which antibiotic, then which route? Then once we stabilize the child, once we start the treatment and child starts improving, then should we go for oral switchover? Then what's the total duration of the treatment? These are the few gray areas that are there. So which child should be treated with the antibiotic? This is basically answered in the British Thoracic Society guidelines. So all children with clear diagnosis of pneumonia should receive antibiotics. So as bacterial and viral pneumonia cannot be distinguished reliably, as I told, it is sometimes difficult to have a microbiological diagnosis. And children below 2 years with mild symptoms may have to be reviewed rather than directly going into antibiotics. And then we need to follow them closely. Once you start antibiotic, think of antibiotic. Which antibiotic should I use? Amoxicillin, amoxicillin, amoxicillin is the first choice. There are alternatives like coamoxiclav, erythromycin or azithromycin, etc. That depends on the clinical condition and your suspected etiology. And macrolides are being used now more frequently whenever there is no response to the first line antibiotic like amoxicillin, or if there is a suspicion of mycoplasma or other atypical organisms. So pneumonia with influenza, we need to start with coamoxiclav. So how should the antibiotic be given? Should I give antibiotic all children with the oral or all children IV? So oral antibiotics is safe and effective even in severe pneumonias. That is, there are some studies like a pivot study which was done in UK, and it has clearly told unless there are complications, the oral treatment is equally effective as IV antibiotics. And IV antibiotics has to be given in a child who is unable to tolerate orally, or if there is a signs of sepsis or metastatic abscesses, or if the child is having a complicated pneumonia. So amoxicillin, coamoxiclav, these can be used, or ceftriaxone or cefotaxime. These are a few options in a severe pneumonias. But in a uncomplicated pneumonia, it is the amoxicillin. So when should I switch from parenteral to oral? There are no randomized controlled studies. There are no clear guidelines, even in the IDSA or BTS guidelines. The parental switch, when we should do. The only thing it is said that there is a clear evidence of improvement. Child's distress comes down, fever comes down, the oxygen is maintained, and all those things when it is there, then probably on an individual case, you can start switching over to oral antibiotics. What is the duration of antibiotic? Because there are a lot of papers telling that short course of antibiotic is also equally good. It is now said that the 3-day course is sufficient to treat the child with pneumonia, but still controversies are there. But WHO recommends 3 days course in uncomplicated pneumonia and non-HIV status. And this is based on many randomized controlled trials. And the Cochrane review by Hyder et al., he has compared 3 versus 5 days course, and it is found that they are equally good. Both are equally good as far as the outcome is concerned. And most of these studies have been done in developing countries, because the type of pneumonia or the etiological factors and the availability of medical facilities different in developing countries and developed countries. Except one study from Finland, which showed that 4 days versus 7 days were equally good. This is one study which was done in a developed country. And we really, if you look at the recent papers, 2020 New England Journal of Medicine, I think the July issue of 2020, you have very good articles throwing light on these things. One is the randomized trial of amoxicillin in Pakistan for pneumonia. So that is one thing. Amoxicillin is found to be very effective. Then second is the 5 days course versus 3 days course in Malawian children. And that particular study showed that both are non-inferior. They are equally good. So having said that, in the clinical, but in the developed countries, they never resort to the short course. They have gone for 5 to 7 days only. And even the most of the textbooks say 5 to 7 days. So antibiotics in childhood pneumonia, how long is long enough? That is the question. So what factors influence the decision on antibiotic duration? The duration is determined by the severity of the disease, the etiology of the child, pneumonia, which depends again on the age, vaccination status, comorbidities, and the prevalent local antibiotic susceptibility profiles. Of course, in some cases, cost, availability, tolerance, and the ease of administration, all this may count when it comes to the adherence. Then advantages of a short course treatment. Why they are talking about short course? In addition to reducing the cost and lesser adverse effects and improved adherence, there is a lower risk of developing antibiotic resistance. But the disadvantage is that the delayed or incomplete eradication of pathogens may occur, which can cause additional morbidity, and we may land up with giving in viral etiology where it is not needed. So having said that, there are a few case scenarios I will be taking. At 6-week-old with fever, cough, breathlessness, and poor feeding, no altered sensorium or SYEARS, but his saturation is around 92, respiratory rate is 62, and there is reduced air entry. So as I told, any pneumonia, this particular triangle has to be applied. You confirm the pneumonia with the relevant investigations and look at the severity and the etiology. And this is the chest X-ray. And the options left, because now in our clinical practice, if you look at each institution follows its own protocol, each individual pediatrician follows his own protocol. So what is the best treatment in this case? So in this case, I have given 4 options, whether to start on parental Genta with amoxicillin, or admit with parental Pictas with amoxiclav and oral amoxiclav, or admit and start on AMP Genta. So this is a very small baby, toddler. So we have to start with AMP and gentamicin parenteral. So this is the algorithm for pneumonia treatment in less than 2 months. So less than 2 months children, babies, if there is a suspicion of meningitis or not, that is the first thing we have to do. If there is no suspicion of meningitis, we need to admit, fluids, oxygen, then AMP Genta. Assess after 48 hours. If there is improvement, improvement in the sense feeding well, no chest indrawing, and then hypoxia is better. So you complete the antibiotics with 7 to 10 days course of IV. If there is meningitis, you treat accordingly with the 3rd generation cephalosporin for a longer course. If there is no improvement, then, or if it is worsening, then we may have to switch over to ceftriaxone or gentamicin for 4 days. And X-ray should be taken. And then if there is a suspicion of Staphylococcus, we may have to add cloxacillin. So second case, a 2-year-old with fever, cough and breathlessness of short duration, 2 days. Again, tachypnea, but oxygen saturation is normal and reduced air entry in the right infraclavicular region. You apply the same triangle, the etiology and the severity. So this is the etiology of pneumonia in various age groups, stratified age groups. Whatever is the age, Streptococcus pneumonia takes the upper hand. In a older child, we can have more of viruses and then mycoplasma in around school-going ages. Staphylococcus and other things, as we know, can be other reasons. So in this particular child, what will you do? Whether you will give oral amoxicillin 40 mg per kg or co-amoxiclav, clarithromycin, ampiclox and cefuroxime, like that. So the options are more, these are not the recommended options. What I'm trying to tell you is these are the things which are being done in practice. So what we have to do is the oral amoxicillin 40 mg per kg dose in 2 divided doses for 5 days. In a non-severe pneumonia, the domiciliary treatment is first line is amoxicillin, then in some cases co-amoxiclav. The standard dose is 40 mg per kg per day. In some cases, I will tell you later, 80 mg. And one thing is that we need to inform the parents about the red flag signs. Anytime the child can deteriorate, and then when to come to the doctor very early. We need to take care of the other things like fever, nutrition and fluids. And one thing is avoid cough syrups. They have no role in pneumonia. So when we communicate in the treatment part, the compliance has to be stressed. The red flags has to be told to them. The red flags is when there is a feeding difficulty, persistent vomiting, lethargy, stridor, grunting, head bobbing. So these are a few common things which we need to tell them as a part of our treatment. The third case is the 18-month-old with the 8 kg, fever, grunting, fast breathing, and reduced oral intake. He had a fever and a rash a week back, has significant failure to thrive, febrile, respiratory rate is 60, saturation is low, indrawings are there, reduced air entry. And what is the etiology and severity? So in these cases, these are the options. I will not go into the details, but this is a severe pneumonia. So the severe pneumonia, we may have to start with if the child is very sick, then we may have to start with injectable antibiotics. IV ceftriaxone is the best option. So in severe pneumonia and malnutrition, the first line would be ampegenta in a small baby for 5 days, or you can start with the ceftriaxone. If there is a suspicion of Staphylococcus, then we need to add cloxacillin, then other supportive measures, and we need to keep the PAC informed in case of deterioration. The fourth case, again, an older child, 13 years, 7 days cough and fever. Fever is very mild with breathing difficulty. He is mildly tachypneic and bilateral crackles are there. He was nebulized. He has this kind of picture, which is bilateral disease, which is more of interstitial and fluffy shadows. You know the diagnosis. And some children of that category may come with this kind of X-ray, which is typical of atypical pneumonia or mycoplasma pneumonia. So we need to start with macrolides in addition to the amoxicillin. If you have a definitive diagnosis, go for only macrolide. Otherwise, in the initial phase, when you have a doubt, start with the amoxicillin, not improving, or if there is evidence of atypical organism, macrolide has to be started. But we need to attempt the diagnosis either by PCR or by serology. So when to suspect atypical organisms? So when there is a systemic symptoms are there, and then cough which persists and worsens. Symptoms are less, the signs are more. There is multi-organ involvement. The next case is an 18-month-old toddler with grunt and fast breathing, and of course, this I think I have told. So the severe staphylococcal pneumonia, I will not be going to tell, because Dr. Tanu Singhal will be touching about these things, including the necrotizing pneumonia. The only thing is that necrotizing pneumonia, we need to think early and we need to start the treatment. But antibiotics, I will just talk about the antibiotics which are used in complicated pneumonias. If there is a susceptible organism, Streptococcus pneumonia, amoxicillin, and clindamycin. If there is intermediate resistant or resistant, ceftriaxone or third generation cephalosporin with the linezolid, staph or is MSSA if it is there, clox or cefazolin. Then MRSA if it is there, vancomycin. Then hospital acquired pneumonia, it is vancomycin. That will be dealt, I think, later. And there is one more variety wherein there are influenza season, lot of cases are there in the community, and this child comes to you with high fever, rhinorrhea, and fever, cough, and tachypnea with retractions. His saturation is borderline, and generally the option is that you should send a swab, then start on oseltamivir, and this is the X-ray which is typical of a severe influenza. So the duration of treatment, when it comes to that, the next option is that it depends on the grading of the pneumonia or the type of pneumonia. In an uncomplicated pneumonia, or if it is a severe pneumonia, we need to give for 5 days. In a severe, very severe pneumonia, which is uncomplicated, for 1 week. In a complicated pneumonia, 1 to 2 weeks we have to give. In staph pneumonia, which is complicated, a longer treatment of 4 to 6 weeks may be needed. So if you have given appropriate antibiotics, you have given appropriate treatment, still the child fails to improve, you need to check the compliance. One is the dose which is given correct, or if the drug given is correct and the method of giving is correct. So these are the things which we need to look at. Then look for the complications in addition to non-pulmonary complications like thrombophlebitis, etc. The complications related to pneumonia like effusion, empyema, and necrotizing pneumonia, metastatic infection, these are to be kept in mind. Then also look for coexisting diseases like cystic fibrosis or immunodeficiency, because unless you treat these things, your treatment is not going to have any impact on the patient. So Whenever there is failure to improve with your routine treatment or recommended treatment, you need to look at these problems. So, friends, once again, I would like to emphasize that whenever pneumonia is there, you suspect, then you confirm, look at the etiology, look at the severity. That is the mantra which we should remember. The summary is that if there is no pneumonia, no antibiotic. Pneumonia, that is only fast breathing, oral antibiotic. Severe pneumonia with the chest indrawing, oral antibiotic. But if there is danger signs, you have to go for parenteral antibiotic. Very severe pneumonia, hospitalization, IV antibiotics, oxygen, and other supportive. So the summary is that amoxicillin is still the first line of drug in most of the pneumonias. The dose of amoxicillin depends on pneumococcal resistance in that particular community. Amoxicillin can also be given in twice instead of thrice also. There are many studies to say that giving twice is equally effective. Macrolides can be given when you clinically suspect atypical pneumonia, especially in children above 5 years. Most of the cases, 40 to 50 mg per kg per day is sufficient. But when there is a resistance, we need to give higher doses like 90 to 100 mg can be given. Other drugs like coamoxiclav and cephalosporins are costly, not to be used as a first-line drug unless there are clear-cut indications, as I discussed. Antibiotic resistance is a major problem, and these antibiotics should not be used indiscriminately. Duration should be 5 days. Though WHO says 3 days in a community level, we should give at least 5 days. But of course, the literature says that shorter courses are also effective. And most important thing in the treatment is that the communication with parents is more vital. And that is the thing which is going to have a larger impact on the treatment. So thank you very much for the patiently hearing. Thank you.
Thank you so much, Dr. Bhaskar. It was really comprehensive, and I think you have touched all the aspects. Now, friends, I will just keep you waiting for another 15 minutes before Dr. Tanu Singhal takes up the stage. She's already busy in another webinar, so I will just deliver the talk on pneumonia mimics before Dr. Tanu Singhal takes up the complicated pneumonia. So, good evening, everybody. Now, pneumonia and particularly chest radiology often poses a challenge to us that what is this? Why are these shadows present? Why is this child not responding? So there are few cases which we might encounter in the course of our clinical practice. Now, this 2-year-old girl who had fever, cough and cold for 2 days, and there were similar episodes previously also. The child wheezes sometimes, and the routine blood showed total count around 7,000 with neutrophil 44, and this is the chest X-ray. Now we have to consider whether this is a pneumonia. As you can see, there are some opacity, whether this is bronchiolitis or whether this is episodic viral wheeze. Well, from the history and from the typical radiological feature, we can make out that it is an episodic viral wheeze, as there were similar episodes before. There was wheeze, and this blood count is not typical of pneumonia, and of course the X-ray. Now this is a 7-year-old boy. This boy is admitted to intensive care unit with acute respiratory distress, but there is no fever. The child is also known asthmatic. The child has been nebulized, hydrocortisone administered. Total count was 19,000, neutrophil 70, and the chest X-ray shows some typical fluffy shadows in both the lung fields, typically in the perihilar region. Is this pneumonia? Is this bronchopneumonia, or is this hyperreactive airway with stress-induced leukocytosis and some microatelectasis, as you can see, mainly in the peripheral region? This is an hyperreactive airway disease. And this leukocytosis, we should not get carried away thinking it's a infective or pneumonia. Most of the time, the stress induced, and the child is having acute severe asthma. Now, again, this is a 7-year-old child, a known asthmatic, has come with fever and cough. And as you can see, there is right-sided pneumonitis. Again, total count 13,800, neutrophil 50. We took a right lateral X-ray, and here you can see the major fissure and minor fissure, the typical opacity of the middle lobe in the right lateral X-ray. Now, what could be the cause? Is it a pulmonary sequestration? Is it a collapse consolidation? Is it a bronchiectasis? Or is the eventation of diaphragm with pneumonia? So what could be the cause? This typical. Now, this is a collapse consolidation. As you can see, how we can make out, this is called the right middle lobe syndrome. Dr. Baldev Prajapati already touched on it. Typically, it's in children with asthma, as was in this child. There is chronic or recurrent right middle lobe atelectasis. It's usually not acute. And the chest X-ray PA typically shows silhouetting of the right heart border and slight elevation of the hemidiaphragm from volume loss, as we can see here. Then on lateral X-ray, there is downward displacement of minor fissure and upward bowing of the major fissure with increased triangular density of the atelectatic middle lobe, as we can see here. The upward bowing of major fissure and the downward displacement of minor fissure with this triangular shadow. This is typical right middle lobe syndrome. There is a 6-year-old known asthmatic child who has sudden onset of respiratory distress. There is mild fever, but the patch disappeared within 24 hours. This was on 1st July, and this was on 2nd July. So if we see this X-ray on 1st July, we have doubts whether it's a upper lobe pneumonia. So what was this? This was a mucus plug, again typical of known asthmatic. 8-year-old girl, fever and cough for 10 days. Initially, cepodoxime was given, followed by coamoxiclav for 7 days. Cough persisted. Leukocyte count was more than 20,000 with lymphocytic predominance. The child was giving piperacillin tazobactam. And here you can see the diffuse opacities in both the lung fields and obscuring the heart border also. So what is it? Is it tuberculosis? Is it pertussis? Is it granulomatous disease? Now, luckily for this child, we had this feature. So we could diagnose it as pertussis. But this type of chest X-ray is often confused with mycoplasma. But we have to remember, in pertussis, it's the patchy opacity obscuring the heart border, typically producing the shaggy heart appearance, as you can see here. Whereas in mycoplasma pneumonia, it's more of an airspace pneumonia, typically in this right middle lobe, what we can see here. So here lies the difference between pertussis and a typical mycoplasma pneumonia. 8-year-old boy treated for right basal pneumonia before. The child is back with fever, cough, not gaining weight, hemoglobin 9, total count 11,000, neutrophil 48, and chest X-ray again right basal pneumonia, as you can see here. Tuberculin sensitivity test was done, 12 millimeter. Sputum CBNAT was sent because this is a recurrent pneumonia. Now, if we see such child, when this child is having a repeat attack of basal pneumonia, should we come to a diagnosis of tuberculosis based on this tuberculin sensitivity test, history and X-ray? Well, there are few telltale features of tuberculosis in the chest X-ray, which is very much suggestive. One is hilar lymph node, as we can see here. Second is this fibrocavitatory lesion that you can see. There is diffuse breakdown and there are fibrocavitatory lesion. And the third is the miliary shadow. Rest, like the basal pneumonia and round pneumonia, are not really suggestive of pneumonia, really suggestive of tuberculosis. So typical hilar lymph node and these features point us towards tuberculosis. 4-year-old girl, recurrent pneumonia, failure to thrive despite good appetite, and the child passes bulky stools. History of salt craving and dehydration in hot weather. Clubbing present. Received a course of ATT due to this prolonged course of illness. Currently, the child is on asthma treatment. The respiratory secretions were cultured and it was positive for Pseudomonas, and there is family history of sibling death in early neonatal period with not passing stool. So this was the serial X-ray of this child. You see, the X-ray was never good, and in all the episodes, first, second, third, fourth, it was various forms of opacities, and all the time the X-rays was going from bad to worse. This is another child, 6-year-old boy, stunted growth, treated for recurrent pneumonia, fever and cough 15 days, again received ATT a year ago. Now we see patchy radio-opaque shadows scattered throughout the lung fields. So these cases, there is no points for guessing. It is typical features of cystic fibrosis. And in these situations, we have to investigate for cystic fibrosis because we have the tools also. And if we do the CT chest, then we can find the areas of consolidation with pockets of lucencies, the typical honeycomb appearance, the thickening of the bronchial wall, the tram track appearance, and the mucus-filled alveoli scattered throughout the lung fields. So these are the typical features of CT chest in a child with cystic fibrosis. So when to suspect cystic fibrosis? Chronic productive cough, episodes of severe pneumonia, particularly with incomplete resolution, recurrent pneumonia, asthma not responding to therapy, persistent unexplained physical signs or chest radiograph abnormalities. Typically these children had all these features, and respiratory symptoms with any clinical features of primary ciliary dyskinesia or immunodeficiency. We have to think of cystic fibrosis. This is a 5-month-old infant, mild fever, running nose, upper respiratory features. There are conducted sounds in both the lung fields. Hemoglobin 12, leukocyte 8,000, neutrophil 50, and we can see an upper zone opacity. The child was given IV antibiotics for 5 days. Repeat chest X-ray, same shadow. What could be the 5-month-old infant? It should strike us. So if we are suspecting it's a case of non-resolving pneumonia, well, the conditions like failure of clinical improvement at the end of 1 week of antibiotic treatment, failure of radiological improvement at the end of 2 weeks, these are the non-resolving pneumonia. So what next? One is lateral chest X-ray or USG chest. Here, this revealed thymus. But from the radiology itself, if we see a 5-month-old infant with this type of sign in the X-ray, typical of the SAIL sign, we should think in the line of thymus. But when there is a doubt between non-resolving pneumonia, then we can do a lateral X-ray or a USG chest, which can give a diagnosis of thymus. 10-year-old boy, recurrent pneumonia, repeated bouts of high-grade fever and recurrent pneumonia on left side. You can see here. Responded to antibiotics each time. So what could be the cause? Possibilities are sequestration, congenital cystic adenomatoid malformation, diaphragmatic hernia, or it's a collapse consolidation with this type of shadows. So in this child, it was a pulmonary sequestration. How to confirm? Either CT chest or CT angio can confirm. Now, what are the features? It's a mass of abnormal non-functioning pulmonary tissue, which has got no communication with the tracheobronchial tree because it's non-functioning, and receives blood supply from an anomalous systemic artery, not the pulmonary arterial system. Usually, like this child, occurs in the left lung, and it is intralobar, so there is chance of recurrent infection, or sometimes it's extralobar, which is associated with other anomalies. Here it was intralobar. 18-month-old girl, moderate fever, recurrent cough since 8 months, treated with several antibiotics and symptomatic therapy, responded each time but recurred. Clinical examination normal, CBC, ESR normal, tuberculin sensitivity test negative. This child had bronchogenic cyst. If we see the shadow here, this child has bronchogenic cyst, and this can be diagnosed by CT scan or also by the indentation in the barium shadow. 5-month-old girl, 3.8 kg, birth weight was 2.5. This is the third episode of cough and breathlessness. The child was ventilated for a week at birth for severe respiratory distress, also sepsis, disproportionately high pulmonary hypertension on echo, and this is the chest X-ray of this child. So there is a well-defined hyperlucent lesion with septation you can find here, and there is atelectasis of the left lobe also. There are bulla or pneumatocyl of the right upper lobe with compressive atelectasis of right lower lobe. Here you can see from the CT chest also. Chest X-ray PA view, dense radiopacities with areas of breakdown of the left lung. Trachea is shifted to the left side, you can find here. What is this? It is the CCAM or CPAM. It's a developmental anomaly of the respiratory tract. The appearance and the clinical presentation, the gestational age at which the anomaly developed, its location within the tracheobronchial tree are all suggestive. So this is the congenital adenomatoid malformation of lung. 11-month-old baby, 3 episodes of pneumonia, afebrile, no distress. There is haziness of the left lower zone of in the X-ray. A USG was done, which showed left kidney in ectopic location in the left subdiaphragmatic region, superior to spleen, and it's malrotated. So this was the false shadow of the kidney, which looked like pneumonia. 2-year-old boy, respiratory distress. This is the chest X-ray. Tracheal and mediastinal shift is there, as you can see. To the right, air fluid shadow on the left zone. If we do a USG chest, left-sided eventration of the diaphragm, as we can see, well delineated upper left dome of diaphragm high up, and position and movement of the hemidiaphragm can be made out by USG also. So it's quite obvious. 5-year-old boy, sudden onset respiratory distress and complained of chest pain and dysphagia. This is a sudden onset, and X-ray showed complete atelectasis of the left lung with mediastinal shift towards left. You can see mediastinal shift towards left. What was it? Bronchoscopy was done by Dr. Pallav Chatterjee, and it revealed these two things obstructing the bronchus. Now, foreign body removed, chest X-ray 2 days after a popcorn was removed from left main bronchus, and resolution of the atelectasis is complete and the mediastinum is in normal position. So this is another cause of opacity in the chest X-ray. 1-year infant, respiratory distress. This is the chest X-ray. Increased density radiating from hilum, and history of intranasal application of oil daily. So this was a lipoid pneumonia due to recurrent aspiration, microaspiration of oils instilled into the nose. 13-year-old girl, dense radiopacity left lower zone. Is it a loculated pleural effusion? CT chest confirms left-sided loculated pleural effusion, though CT is not a mandatory investigation, but this child came with a CT scan from outside. That's why I'm showing. 6-year-old boy, dense rounded radio-opaque shadow in the left upper zone. Margin is well delineated, gradually developed both lower limb weakness and upper motor neuron type of paralysis. This was SOL in the left upper lobe, in the posterior mediastinal. This is typically a neurogenic tumor, location in the posterior mediastinum. The neurogenic tumors originate from in the posterior mediastinum, and this was a neuroblastoma. 10-month-old baby, afebrile, presents with respiratory distress. Now, this is a difficult chest X-ray. If you can see here, there are costal hyperostosis, what we find in Caffey's disease. Thickening of the ribs, you can see here, with almost uniform, alternate dense and radiolucent laminar bony thickening of the right side. Blood parameter were done. Typically, the platelet count was high. Here, the distress is due to the entrapment of the intercostal nerves, and even the phrenic nerve may also be involved. So the distress is due to the entrapment. The child is afebrile, and these children typically present with respiratory distress. So if we see the overview of pneumonia mimics, the characteristics that can have mimics, one is clinical, that I was just telling. Then of course radiological, that we have been seeing for so long, and even Dr. Prajapati has shown, and then laboratory. There may be reactive lymphocytosis also that we have discussed. So it may be clinical mimic, it may be radiological mimic, and it may be laboratory mimic also. What are the causes? Once we suspect a pneumonia mimics, we have to keep at the back of our mind unusual infections. And of course, the second most common cause are the non-infectious causes like foreign body and others that we have discussed. So thank you, friends. Thank you for your patient hearing. Now, we are happy that Dr. Tanu Singhal has joined us, and I would like to welcome her. Dr. Tanu, please take over the stage. The next 20 minutes is for you. So over to Dr. Tanu Singhal.
Yeah, good evening, Dr. Jaideep, and thank you so much for covering for me. And is my screen seen?
Yeah, we can see your screen, Dr. Tanu. Thanks.
So I'm going to be basically talking about complicated pneumonia here. And the first question is that what is complicated pneumonia? So I have classified the complications into two. One is pulmonary and systemic. Now, parapneumonic effusion and empyema are the commonest complications that we see in day-to-day practice. And maybe I would say 70 to 80% of all the complications that we see. And that is actually challenging to manage. And I have a case for that. Then we have this necrotizing pneumonia and lung abscess also, which we see sometimes, especially in staphylococcal infections or in immunocompromised children. And then you can also have patients who develop a bronchopleural fistula following a pneumonia and a pneumothorax. And then apart from that, you have systemic complications, like you can have septic shock in a child with severe pneumonia. You can have ARDS, which actually is not clearly a systemic, but maybe a pulmonary complication only, or respiratory failure. Then you can have the syndrome of inappropriate ADH secretion also, which we must remember. And that is why if you have a very sick child admitted with pneumonia in your unit, you should do a sodium estimation in this child, because many of these children are drowsy because of low sodium, and correction helps these children. DIC is seen sometimes, and hemolytic uremic syndrome is described after pneumococcal pneumonia, and often you see this phenomena of secondary thrombocytosis, that you see children who are recovering from pneumonia and they have a high platelet count, and that can be either due to iron deficiency anemia or because of the inflammation as such. And there are some studies which say that if a patient has thrombocytosis with pneumonia, the outcomes are poorer because the degree of inflammation is actually high. Now, how do you approach a case of complicated pneumonia? So the first is, when do you suspect? I mean, it's clear that if normal patients whom you treat for pneumonia start improving in 48 to 72 hours. So if your patient with pneumonia is not improving in that time, or has improved, or and then deteriorated, that would be the point in time where you would think of a complication. So you have started an antibiotic for a child, and after the fever goes away and 3-4 days later the fever comes back, then you should suspect a complication happening. And how do you evaluate these children? Of course, you would review the history again, because you would want to find out more carefully, why is this patient not improving? Would it give you an indicator of something else happening in this patient? You would do a physical examination, which we have often forgotten. So you should actually check these children carefully. You should examine the chest, percuss the chest. You should also look at other sites to see if there's any metastatic infection elsewhere. And you should do a careful head-to-toe examination in these children. X-ray is, of course, very important. And all patients, in patients that you have, you would do an X-ray at admission, and then you wouldn't do a follow-up X-ray. But if you're suspecting a complication, an X-ray is mandatory. Similarly, if you're suspecting an effusion or empyema, an ultrasound chest is a good thing to do. And nowadays, ultrasound is being used widely even to diagnose pneumonia, and is particularly important even in COVID. CT chest may be needed in some patients, like where you really want to, where your X-ray and ultrasound doesn't tell you. But at the same time, you should not go around doing a lot of CT scans, because then you often overdiagnose certain things. Obviously, you would do the CBC CRP, because if you have a child with pneumonia who comes with leukocytosis and high CRP, and then on follow-up, the child's not improving and the CBC shows a white cell count and CRP going up, you know that a complication, a suppurative complication may have occurred. If the child has a pleural effusion, you would tap that effusion, and to distinguish between a parapneumonic effusion and an empyema, and also the etiology of empyema. And very rarely, you may have to do a bronchoscopic lavage, especially in an immunocompromised host, to find out the etiology if the pneumonia is not improving. And of course, management really depends on the cause of the complication. And it will maybe it will involve a change in antibiotics, like adding an macrolide if it's not given earlier, or adding an anti-MRSA drug. And what we do commonly in practice is drainage of the pleural fluid, either with a chest tube, with or without fibrinolytics. And in some cases, you may also have to intervene surgically. And another important thing in a complicated pneumonia is that you have to follow up the patient till there is radiologic resolution. So, like in normal pneumonias which have improved, we don't recommend a follow-up chest X-ray. But if your patient has a complication like an effusion empyema, you should do an X-ray after 6 to 8 weeks to make sure that everything is fine and the lung has expanded well. So I have basically two quick cases to try and show you two complications of pneumonia in which we saw in our clinical practice. And the first is this case of a 15-year-old girl who had come with fever, cough, and chest pain for 1 week, and she was treated on an outpatient basis with antibiotics, but she didn't get better. Her chest X-ray showed lobar pneumonia with effusion. She was admitted, but fever persisted. And that point in time, they did a CT scan, which showed that she had a thick pleural fluid there. So she was actually came to us for pleural drainage. And at the time of admission, she was febrile. She had a little high respiratory rate, and she had reduced air entry on the right side. Now, when you look at her investigations, you find that she had leukocytosis with 80% polys, high CRP. And if you look at the CT scan which she carried with herself, you find that there is a thick, peeled here, a thick pleural fluid over here. And of course, you see the underlying pneumonia as well. And of course, she came to us and we started her on antibiotics. And then we also decided to put a pigtail. So we did an ultrasound guided pigtail. But even after putting the pigtail, basically we couldn't drain any fluid. So at that point in time, we thought that maybe the fluid is very thick. And we started intrapleural urokinase at 50,000 units daily for 3 days. And following putting the urokinase, we started getting some amount of purulent blood stain fluid. But when we did an X-ray for her, we found that she also had developed a pneumothorax, which was like a hydropneumothorax. So actually, in this patient, over the next few days, the fever declined. The white cell count came down from 19,000 to 7,000. The CRP declined to 3. But the pneumothorax persisted, and basically her air entry continued to be less, and the pleural that drain stopped draining after 3 days of urokinase. So we removed the drain, and we put in a pigtail to drain the pneumothorax, because earlier the drain was there in the base of the lung. And when we put a drain here, we found that she had continuous bubbling into the water, and therefore she had developed a bronchopleural fistula. But then over time, the air reduced and stopped. But the pneumothorax persisted. You can clearly see on the X-ray, because we had removed the drain, the pneumothorax drain, but the pneumothorax persisted. Air entry continued to be low on the right side, but no other symptoms. So at this point in time, we removed the drain and we discharged the patient, and we thought that her fever is gone, she's better. So maybe over time the lung will expand, and the pneumothorax will also resolve, and she will not need any further intervention. But when she came 3 weeks after discharge, though she had no symptoms, but the air entry was still less on the right side. And if this X-ray, if you see, showed that the pneumothorax had persisted. And when we did a CT scan for her, you still see this loculated pneumothorax, this thick peel, and you find that the upper lobe of the right lung is quite collapsed. Now, at this point, it was very difficult to explain to the parents about what to do, because the child was completely asymptomatic, and there was a huge discussion about whether we should leave her alone or do something for this lung, which is still neglected. And then finally we took a decision to for an operative intervention, because we were worried about her pulmonary function later. And we started with the VATS, but it had to be converted to a mini thoracotomy. The pleural tissue was removed, the lung expanded, and the histopath showed acute suppurative inflammation. And this is the X-ray which you see, where the pneumothorax has gone and the lung has completely expanded. Maybe you see a little bit of fibrosis here. So, I mean, what does this case tell you? The case tells us that, you have to do the right thing in the patient at the right time. So maybe when this patient came to us, she was not a suitable candidate for a pleural drainage by a pigtail, and especially when we found that after putting in the pigtail, there was no pus which could be drained. Then we just kind of wasted time doing the intrapleural fibrinolytics and all. And then, eventually the patient did need an intervention, and now she needed a thoracotomy instead of a VATS. So just to revise, how would you approach drainage of effusions or empyema? You would first categorize the size of the effusion. If it is a very small effusion, then you can, these are not tappable, so you can continue antibiotics and follow up these patients. If the patient responds to therapy, you continue the antibiotics. If the patient does not respond, you reassess the effusion size. Now, if the patient has a moderate effusion, which is basically opacification of less than 1/4 of the hemithorax, but less than half, then you should tap it. And here you should try and distinguish whether it is a parapneumonic effusion or an empyema by the standard criteria like the pH and the visual appearance of the fluid, LDH, etc., or presence of organisms on gram stain. And if it is just a parapneumonic effusion, you don't need to put a tube, and you can just continue antibiotics. But these patients also you have to watch, because if their fever continues, then they may actually convert into an empyema, and you may have to intervene later. And there are some patients, where they have a moderate effusion, and they have been ill for a long time, their fever is high, their counts are high. There that this is unlikely to be a parapneumonic effusion, and it's an empyema. And rather than doing two things, first doing a pleural tap and then putting an ICD, you can actually go ahead and put an ICD straight away without evaluating here. You can straight away do a drainage. And also that is true if you have a very large effusion which is causing respiratory compromise, you should do a drainage up front. And if the fluid is thin and there are no loculations, you just do a test tube. If the fluid is loculated and is thick, then you could put fibrinolytics like urokinase, or you could go for primary VATs. There are studies here to show that whether you put in do fibrinolytics or you do a VATs, the outcome is the same. But if your patient has thick fluid and if you see peels present on the ultrasound or CT, then in such patients it's better to go ahead and do a VATs directly, because some these patients are likely to fail, and such was our patient. Basically when she came in, she already had thick fluid, and maybe it would have been better to do a VATS. Then let us come, Dr. Jaydeep, do I have any time?
No.
How much time do I have?
No, you can please continue for another
Okay.
10 minutes. Is it okay?
Okay, fine. I think I should finish in 5 minutes.
Okay.
So that is about the commonest pulmonary complication that we see. And this is a second case, which I wanted to just show you to see that, what high-end critical care a child needs with severe pneumonia. And this is a case courtesy our intensivist, Dr. Preeta Joshi, who managed this patient, and the PICU team. So this was a 12-year-old previously healthy male who had fever and cough for 5 days and who had breathing difficulty for 1 day. And this patient had a chest X-ray done, and it showed a bilateral pneumonia and massive left pleural effusion. And I'll show you the X-ray in a minute. He was basically admitted to another hospital, and he had to be intubated soon after arrival. And he also had shock, so he was put on inotropes. But his saturation was not good, so he was transferred to our hospital. And when he came in, he was having a heart rate of 134 per minute, a BP which was 110/60 on adrenaline. And imagine his saturation was just 45 to 50% on bag and tube ventilation, and he had a mildly prolonged CRT. And when we examined his chest, his air entry was reduced bilaterally, left more than right, and the liver was 4 centimeter pushed down, and the spleen was not palpable. So clearly a child who's having a very fulminant pneumonia and respiratory failure. And this is his X-ray, because when he came in, he basically had a tube in, and here you can see that there was a massive effusion on the left side. So he was shifted to the ICU. He was started on high frequency oscillatory ventilation, and he was started on antibiotics. I mean, with this patient, they didn't know what it was, so he was started on meropenem, vancomycin, azithromycin for atypical cover, as well as oseltamivir. Of course, this kind of pneumonia doesn't look like, with such a large effusion, doesn't look like influenza, but nevertheless, it was started. He was also given methylprednisolone for management of respiratory ARDS. Arterial line was put, central line was put, Foley's catheter was put, a left-sided ICD was put because he had a massive left-sided effusion. But despite all this, his saturation was 40%. And if we wouldn't do something quickly for this patient, we knew that this patient would die. And by this time, in the next 2-3 hours, investigations came in where he had a high WBC count. He had 90% polys. He had borderline platelet count. He had a high CRP and procalcitonin, deranged liver enzymes, and a normal creatinine. And we did a nasopharyngeal swab because of this case. And there we found that mycoplasma was detected. And also he had human rhinovirus or enterovirus detected. So obviously, we had never seen a patient with mycoplasma with such serious a pneumonia who was not even maintaining saturation on maximum ventilatory settings. So at that point in time, because we have facilities for doing an ECMO in our hospital, we shifted this patient for a veno-venous ECMO. Basically, for understanding a veno-venous ECMO is where you basically withdraw blood from the venous side and you pass it through the machine which is used for cardiopulmonary bypass, and you re-inject the blood in the vein. And apart from this, you also have a VA ECMO where a patient is in shock. So in that case, you basically withdraw the blood from an arterial line and you inject it into the venous line. So in this patient, because the blood pressure was reasonably okay, we did a VV ECMO, and we also inserted a right-sided ICD, and he basically required lots of other supportive medications to paralyze him and sedate him. And because there was mycoplasma at that time, he was given dual anti-mycoplasma therapy with azithromycin and minocycline. And meropenem and vancomycin was still continued. Now there's a debate about this, that now that you've got a diagnosis of mycoplasma, would you just continue with anti-mycoplasma therapy, or because the patient is very sick, would you like to give other antibiotics alone? Also, and personally, I wouldn't have used such broad spectrum antibiotics because I know that this child has a very long road ahead, and therefore you would like to use these antibiotics later, when he gets a secondary infection. And maybe if I would give ceftriaxone here along with the anti-mycoplasma therapy, because you know that unlike viral infections, in cases of mycoplasma, co-infections are uncommon. But the argument of the intensive care team was that this mycoplasma, which we have picked up in the upper respiratory tract, may just be a colonizer, and we don't know whether it is the actual pathogen or not, and therefore we don't want to de-escalate antibiotics. So day 3 of hospitalization, because this patient was now on VV ECMO and we could safely do a bronchoalveolar lavage, we did a bronchoscopy and bronchoalveolar lavage. And basically now you have the pneumonia panel also, which you can send. And when we sent a pneumonia panel, which picks up more pathogens than the upper respiratory tract panel, again we found that mycoplasma was detected. And here the rhinovirus and enterovirus was not detected, telling us that the rhinovirus and enterovirus that we had picked up in the upper respiratory biofire was actually a colonizer. And so, apart from the mycoplasma being positive in the BAL, the mycoplasma IgM also was positive. And this child had a rapid fall in hemoglobin. And when we sent his cold hemoglobin titers, it was 1 in 128. So now in this patient, and his blood cultures were negative. So now in this patient, we have ironclad evidence that this complicated pneumonia with ARDS and respiratory failure is because of mycoplasma and nothing else. So at this point in time, this patient, over the next 10 days, we gave actually 3 anti-mycoplasma drugs. Now, again, you would argue that whether this should be done, and there's no data to say that, you have to give extra therapy for mycoplasma. But the issue was that this patient was so sick and he was on ECMO. And if you look at his lungs, they were all consolidated. This is the VV ECMO cannula that you can see here. And this is the ICD, which was present on the right side. And at this point in time, we also gave this child pulse methylprednisolone because there is some data that in severe mycoplasma pneumonia, you can give pulse, and we gave a pulse of 30 mg per kg or 1 gram a day. And in this patient, because his hemoglobin had fallen, we gave him a transfusion and he developed a severe hemolytic reaction. And that was because of the cold agglutinin. So we had to actually warm the patient, increase the temperature of the patient, and run the blood through a warmer to increase its temperature so that we could give a transfusion safely to the child. Because otherwise, if you would give a transfusion, he would hemolyze and the situation could become worse with renal injury. This child problems were not over. He had developed a pericardial effusion with tamponade, for which we had to insert a pericardial pigtail. And he also developed secondary sepsis by now, for which we had to treat with poly B. And if you look at this patient, day 10 to 20, now this child develops subcutaneous emphysema, and left-sided ICD was reinserted, and he was weaned from ECMO and decannulated on 14 days after the starting initiation of the ECMO. And you can see that how many problems he had to face before he finally was decannulated. Now, one of the reasons for doing an ECMO is that you can reduce the pressures of the ventilator and therefore your barotrauma goes down. But in our patient, it seemed that he continued to have significant barotrauma. And then between day 20 and 30, we had to wean him from the ventilator. He was extubated on day 20, went on high frequency nasal cannula, then room air, both ICD were removed. And if you look at the CT at discharge, it still shows quite significant fibrosis and presence of bully. These are the kind of CTs you see in COVID adult patients, who go home. But fortunately, over a 1-year follow-up, the child has regained normal lung function. So, what are the learning points from this case? The learning points from the first case were that you have to choose the right drainage procedure in a patient. And the learning point from this case is that mycoplasma can cause very severe pneumonia and ARDS. And, in this patient, the boy could survive. because the family could afford ECMO and we had it in our institute. And one must also always remember that, if you have a patient with very severe pneumonia who's not doing well on mechanical ventilation, and if the family can afford it, you should transfer the patient to a center which can offer ECMO to this patient. So in very select circumstances, so you should remember that the back of your mind. And again, the issue is that role of triple therapy here, because we use azi, minocycline, and levofloxacin, whether there was any role or not, but we know that there is macrolide resistance in the offing. So probably dual therapy may be justified, if not triple therapy. Also, the role of IV methylprednisolone is to be considered if you have a patient with mycoplasma and severe pneumonia and has immune manifestations, like this child had a immune hemolytic anemia. And we have learned to respect mycoplasma over the years. So I was recently in another meeting where the other panelists were saying that mycoplasma they don't see, and they don't see severe mycoplasma. It's a walking pneumonia, but that's not what we have seen. We've seen very complicated infections. Like, we've seen people who needed ventilation. We've seen patients who developed ARDS. We've seen two children, one of whom developed deep vein thrombosis and the other one who developed a stroke because of a prothrombotic state. And immune hemolytic anemia we've seen apart from this case. And finally, we also had a child who came with mycoplasma pneumonia, and following which he developed a Kawasaki disease. So mycoplasma is also another bad pathogen like COVID, where immune dysregulation also has a role to play in the manifestations. So I think with that, I would like to end here, with these two cases of complicated pneumonia, and thank you so much.
Thank you, Dr. Tanu. As usual, your presentation is comprehensive, is informative, and it's an eye-opening also. So thank you so much for joining. Now, as we see that pneumonia often pose a challenge, and it's often very difficult to treat. So prevention is the key. And to discuss prevention, we have an eminent panel led by Dr. Vijay Yole. And panelists, we have Dr. Balasubramanian, Dr. Chitkara, and Dr. Pallab Chatterjee. So over to Dr. Vijay Yole for the next few minutes of a very interactive and interesting discussion.
Very good evening, friends, and compliments to Dr. Jaideep Chaudhary for organizing such a wonderful CME on pneumonia on the eve of World Pneumonia Day, the #1 killer of under 5 children world over. And India, unfortunately, is the leading contributor to this pneumonia mortality and morbidity. Let me formally welcome all my friends and the experts on this panel. Dr. Balasubramanian from Kanchakamakoti Child Trust Hospital, the director of KKCTH. Then we have a very senior pediatrician, infectious disease specialist, Dr. Amarjit Chitkara, who is a senior pediatrician at Max Hospital, New Delhi, and has been into pediatric practice for more than 4 decades. And then we have an equally, eminent and renowned pulmonologist and infectious disease person, Dr. Pallab Chatterjee from Kolkata. I welcome you all, and let me start sharing the screen and walk you through this, issues in prevention of this deadly killer of under 5 children. So, as I said, tomorrow is the World Pneumonia Day, and there are various organizations and associations which have come together to create awareness and to plan what best can be done to prevent this #1 killer. And every breath counts is the theme that is put up for this year. And here we are discussing the prevention of pneumonia after such wonderful talks by 4 experts on different aspects of pneumonia. In 2019, about 672,000 children died of pneumonia. And what is special this year is the corona pandemic or COVID-19 pandemic, which could add another 2 million to the death toll of pneumonia, primarily in adults, of course. And then it is expected that all-cause pneumonia would go up by 75% by the end of 2020. Then all of us are pretty well aware of the disruption of healthcare services which has occurred, which would add to our 2.3 million child deaths. And 35% of this would be because of pneumonia. So it's a huge, huge problem, and to a great extent preventable. There have been different coalitions which have come together, and there is a very popular global action plan for prevention of pneumonia and diarrhea, because these two diseases, number one and number two killers, tend to occur in the countries. They appear to be common to these developing countries, and most of the interventions have common implications, and these common interventions can help bring down both. And if you look at the different aspects of this integrated action plan, which is also run by our country, you have three-pronged strategy. One is to protect a child against pneumonia, prevent pneumonia in a given child, and treat the pneumonia appropriately. Now, if you look at the different aspects of protecting a child against pneumonia, we have exclusive breastfeeding, complementary feeding, multivitamin, zinc, and vitamin D. So at this point in time, may I invite Dr. Balasubramanian to throw some light and give his comments on how best to implement these practices. What are his opinions on this breastfeeding, complementary feeding, and various micronutrients and vitamin as a preventive strategy or protective strategy against pneumonia? Dr. Balasubramanian, please.
Thank you, Vijay. Regarding exclusive breastfeeding, there is absolutely no doubt it will definitely reduce the incidence of pneumonia in young infants. There is enough data. There is absolutely no doubt, because of the immunological advantages, because of the better nutritional status in exclusively breastfed infant, also because of the reduced risk of aspiration pneumonia in exclusively breastfed infant, etc. So definitely exclusive breastfeeding, yes, a big yes, I would say. Regarding complementary feeding, appropriate complementary feeding is essential for good nutrition of any preschool child. Good nutrition, obviously, your chances of pneumonia are definitely less, and your prognosis for pneumonia is definitely better. There's no doubt at all. Coming to vitamin A supplementation, the only definite evidence of vitamin A being useful in preventing pneumonia, evidence-based data, is for measles and to some extent in HIV. Other than this, there is not great data on vitamin A supplementation. Fortunately, the very incidence and prevalence of vitamin A deficiency in India has come down drastically. I remember when I was a student there, when I was a medical student, I used to see eyes popping out due to vitamin A deficiency. That doesn't happen anymore. Vitamin A deficiency is more due to secondary causes than due to primary nutritional problem. Coming to zinc, there have been some weak data that if you give zinc to infants starting from 2 months of age up to 5 years, in some, I don't remember which country, I think it's in Mexico and some African countries, it had shown some reduction in the incidence of pneumonia, but few other studies have not shown a great beneficial effect. Nelson's textbook used to mention in the previous editions has now omitted it. Vitamin D, if you have a severe vitamin D deficiency in a young infant, definitely it's a risk factor for pneumonia, but there is no hard data that vitamin D in more than therapeutic, more than preventive doses is going to prevent pneumonia, including COVID-19. That's my brief answer for you, Vijay.
Excellent. As crisp as ever, and very clear thoughts and very well expressed. So all of us understand that vitamin A does play a role, and then we have the National Vitamin A Implementation Program, which is happening in all public health sectors. And as you said, zinc, there are a few studies which talk about positive impact, and some don't. And vitamin D, as all of us are well aware, that it has been implicated in causation and used as a preventive tool for anything and everything on this earth. May I ask Chitkara and Pallab if they have anything in addition to what Dr. Bala has said to add to this preventive aspect of pneumonia? Chitkara, would you like to add?
Bala never leaves anything to be commented upon.
Absolutely.
Except for a statement that everything, including micronutrients, responsible for the integrity of our epithelium, be it respiratory or mucosal, is important. And these are the various features which he is already listed beautifully. Would kind of maintain that integrity and a kind of barrier to infection.
Absolutely. Palab, you have anything to say?
Nothing extra. Only thing is that we need to be careful about introduction of what complementary feedings we are giving when, and whether the child is developing allergy to it. So maybe that allergic component can have these children develop pneumonia and all these episodes. So early institution of various products can cause allergic rhinitis, allergic complications in these children, asthma in these children. So that are things, these are things that we need to be careful of. Otherwise, I think I totally concur. Yes.
Yeah, and that's extremely important. And all of us are pretty well aware of the concept of first 1,000 days nutrition, which begins very well in the mother's womb and extends for 2 years beyond delivery of a newborn baby. And malnutrition is an important risk factor for both these infections and major killers in developing countries. Now, the prevent under the prevent aspect or strategy, you have different interventions. You have vaccines, which we'll touch upon a little later. But then there have been other, factors which have been looked at mainly by the public health, the household air pollution. We know even today in rural India, there's a lot of household air pollution because of the firewood that is used, and then improper, many times there is things are burnt in open, and that definitely adds to indoor air pollution, which triggers sort of sets the ground for infection by disrupting the natural barrier of the respiratory epithelium. I would want Dr. Palab to comment on this. Before that, let me mention HIV prevention is an important part of pneumonia prevention. And those who are infected with HIV, we are well aware of the pneumonia, interstitial pneumonia that these children get. And Dr. Baldev Prachapati touched upon this during his talk on radiology pneumonia. So now, Dr. Palab, how does household air pollution lead to pneumonia, infectious pneumonia?
See, there are a few things. Number one is that use of these various wood and all these burning material. Yeah, so coal and charcoal in the house, and people are staying in small compartments. So what is important that we need to look into is a good ventilation. So if there is good ventilation in these households, and these children should not be like exposed to throughout the day to these indoor pollutions. The second is smoking in the house, and smoking. So that is there not only in the rural areas but also in the urban areas, where the kids mainly are exposed to various smoking by these parents. And the third very important thing is molds in the house. So damp walls and molds, these can cause a lot of respiratory problems and fungal infections, and they can lead to pneumonia. So these are things that we need to really look into in these children. So to improve the indoor air, because what has been seen is in pneumonias and in cases like asthma and allergic rhinitis and all these cases, indoor air pollution is much more important than the outdoor. So whether the house is close to the highway and all these things, though they are important, but more important is the indoor air pollution that we see. So that has to be improved.
While Dr. Pallab addressed the issue of indoor air pollution, Dr. Chitkara, we keep reading about the bad air in Delhi. Of course, Bombay is no great deal of a difference. We keep reading about the fog and smog. And so I'm sure you must be seeing a lot of respiratory ailments during these foggy months and during this polluted air. Pallab just mentioned that what is definitely associated and attributed is the household air pollution or indoor air pollution. What is your opinion on this air pollution and the kind of weather that we see in metros these days?
Well, I agree with Pallab entirely because, like Bala said about integrity of an epithelium, At the same time, there are certain environmental factors which set in some kind of an inflammatory reaction into the epithelium, which facilitates the entry of the bugs, which are more prevalent during a little chilly weather or winters in, especially in northern India. So therefore, I have facilitators with a lot of viruses circulating, and the child gets prone to all these respiratory infections. It is not uncommon to see children who have never had any respiratory problems earlier on, with no kind of a significant family history, or de novo, even infants, young infants, coming with all those cough illnesses associated with coryza, indicating that it's a viral infection. But why should a 1 month, 2 months be kind of having a respiratory distress with radiologically no evidence? The child has no fever at all. So I think pollution is taking a toll. And just to update you, we have anything between 600 to 900 AQIs in Delhi right now. Now, indoor, if I, some of those air purifiers which we are using, which have got the digital display, if I keep it indoors, sometimes it shows 600, 700 plus. When I keep it in my veranda or a courtyard, it shows 450. So therefore, there is something more which is adding on to the pollution, which is coming from outside, plus indoor, which we seldom kind of think as an important. Like most of us are in a habit of God fearing and lighting those incense sticks, dhoop agarbattis, dusting. So the lot of these suspended matters, they once again, those which have settled on the cupboards or the books or the shelves, we tend to again push them into the air. So my last, I think 2 weeks or so, our air purifiers have never gone below the red indicator. They are always in a red or sometimes in the orange. So pollution is one of the important factor, not as a causative, but as a facilitator of the causative bugs which are circulating at the moment, and also not forgetting the kind of poor cough etiquettes we have, the overcrowding we have, the rush, and taking children to all those crowded places because it's a festive season. So everything, it is a kind of a multifactorial which is happening these days, and pollution is probably a pivotal factor.
And are you a strong advocate of air purifiers, especially during such seasons?
No, there is a गालिब का शेर है, दिल को बहलाने के लिए गालिब ख्याल अच्छा है. So we just spend our money on these gadgets.
Yeah, I got the answer right. Okay.
Yeah.
Okay.
So
Dr. Bala, now
you spend money and have a good kind of a feel good factor. That's all.
so I'm sure all the panelists are in agreement that passive smoking has role in propagation of respiratory ailments and pneumonia as well. Dr. Bala, what I want to ask you, I see lot many classes and classrooms or those private classes which go on in very close, congested rooms with no ventilation and air-conditioned classroom, where God knows whether the air conditions are serviced at regular interval or not. How conducive are such environment for pneumonia, causation of pneumonia?
All I know is that anybody, including you and me, if we have an air conditioner, the filter should be cleaned at least once a week. That's a must. Second, the older your air conditioner is, the less effective it is. Third, in these corona days, many doctors have got infected by sitting inside air-conditioned rooms without exhaust and exposing themselves to patients with COVID-19. So that holds good. It is not enough if you have an AC. You have to have a good AC with all the conditions for proper circulation. And if you are working in a, or if your child is going to a school, ideally the school must have a system which is foolproof. Otherwise, the risk of cross infection is very high. The risk of children exposing themselves to polluted air inside the air-conditioned room very high. Imagine, suppose there is a small school, and if a child is AFB positive, the child is going to cough inside the AC room. That is disaster.
And Pallav, I remember there was a news about 2-3 years back in from Thane of Mumbai, where there were cases of pneumonia in following a 7-day long conference in an AC auditorium, and the AC was not serviced for years, and Legionella pneumonia was implicated. So, do you agree with this kind of? I mean, what Dr. Bala said is it is important to maintain all these air conditions and air conditioned rooms. So, do you have anything to say about Legionella and other kind of pneumonia
Yes.
triggered by this kind of environment?
Yes, yes. Two things are very common. One is this Legionella pneumonia, and the other one is Alternaria, is another fungal infection that can come from these AC ducts. So what happens is, if anytime we see somebody cleaning these AC ducts that are there in the hospitals, and very rarely they are open, it will be all fungus inside. So it is very, very dangerous to have this central AC. It's much better to have individual air conditioners in the rooms rather than have a central air conditioner which is rarely, rarely opened. And unless it starts dripping from somewhere, and then they open it and then they start cleaning it. So, and if regular management of these cleaning of these ACs is not done, then it is extremely bad. And there were quite a few. Not only this, there was another study that was done in Bangalore, where they saw the incidence of pneumonia and asthma in policemen who were in the crowded road intersections, traffic police, and among those who were working inside the police stations. And they found that the incidence of pneumonia and asthma was much more in those who were inside the police station than those who were in the traffic intersections, working in the crowded traffic intersections. So indoor pollution and this one they are all very important. So these all go hand in hand. So we have to be very careful.
Okay, I really do not know how relevant is this, but this just, I mean, I'm thinking aloud with you. In Mumbai and many metros, we have a lot of, apartments and buildings where builders try to grab as much as possible in the FSI, and they have dry balcony concept. And if you go to these dry balconies, which are just outside their washrooms or bathrooms or balcony, you have a lot of pigeons and pigeon droppings.
Yes.
How important is that from, I mean, does that lead to respiratory ailments and pneumonia?
Extremely important, because what happens is these pigeon droppings, they are quite acidic. So once these children and anybody, they start inhaling this, it is a very important source of hypersensitivity pneumonitis. So people will be sort of going on treating these children with anti-asthma medication and antibiotics and all that. But the actual, until you get that thing treated and you give them a course of steroids, and it depends on what is the duration, whether it's acute, whether it's chronic, this hypersensitivity pneumonitis, it's very, very difficult, and it can lead to a permanent damage to the lungs. So it's very important not to be exposed to these pigeons and all.
Yeah, Dr. Chitkara wants to add something.
Just about air conditioning, which was mentioned. See, today, if I open my doors and windows, I am flooded with air which is laden with bad kind of quality, whether it is 2.5 micron or a 10 micron. So construction is an ongoing activity in a country like India, be it in your neighborhood or maybe in your colony. So what I have realized in last 8 months, because we have been discussing air conditioning and exhaust for COVID also, it is important in the context of all respiratory illnesses, I would say. So what I have learned and gathered experience in last 10 months is keep your AC on, but there should be an exhaust which creates kind of a negative pressure and air change. What do I end up with? I end up with more electricity bills, because that to maintain that desired temperature, the AC keeps on working. So one, that is a cost I am incurring. Fortunately, in my last 8 months of operation in my clinic, which is in a basement, centrally air conditioned, with 14 people working around the clock, with anything about 100 to 150 footfalls per day, some of them also COVID, who are yet to be diagnosed or with the contact history of, none of my staff or none of my patient has really complained. I would not vouch for the patients, but my 14 staff working almost 12 hours in a day in shifts have not got COVID. So I have escaped, not probably because of a luck, but because of the due precautions which we are taking. So I would say in winter, this kind of a pollution, I cannot switch off my AC. When it was extreme summer, I could not have switched off my AC. So yet air changes with an AC on, and footing that extra electricity consumption is probably the key to all this.
Well, very happy to learn that you have escaped Corona, and may you continue to do so for till the Corona is here. Well, Dr. Bala, dengue is there everywhere. Mosquito menace is there everywhere. And a lot of people use this mosquito repellents. And then some of these, in heavily infested areas, especially in slums, they also use those mosquito coils, which emit a lot of smoke. How, does that contribute to, is that dangerous? Does that lead to pneumonia?
Two things. Amongst the mosquito repellents, the most effective is the most toxic, unfortunately. The most effective is permethrin coil, the mosquito coil. Unfortunately, the most polluting is the mosquito coil. The least harmful is your topical lotion and creams containing citronella or some mild insecticide. I'm not remembering. There's some amide which contain. It works hardly for 3 hours. Your mosquito creams work for 3 hours. These coils are highly effective, but unfortunately, they are fraught with the risk of, again, hypersensitivity pneumonitis, increase in the risk of asthma, again, increase in the risk of pneumonia. In between is your mosquito liquids. They also are not good because they contain hydrocarbons, kerosene. So none of them is safe. The best is a mosquito net, or you must get out of India.
Okay, very well said. Okay, now let us quickly move on to a case. This was a 2-month-old child who was brought with difficulty in feeding, had very mild fever, had cough for 2 days, and on X-ray he showed right upper zone patch. And when interrogated, there was history of this baby used to get a nice royal oil bath every day, and they used to put oil everywhere on the fontanelle, in the ears, in the nose, and this kind of customs go on in many communities. Pallab, what is your experience? How risky is oil installation in the nose, and could that lead to pneumonia? And is that an important thing to prevent from a child from getting pneumonia?
Yes, definitely. This is one of the common causes of lipoid pneumonia. And not only that, I've had patients who have one full pallet full of oil they put into the nose. So that sounded very strange, but that's what they do. So fortunately, in our part of the country, it's not that common, so we don't see that much. But it's very common in Dr. Bala's part, where in Tamil Nadu and all, they do it very, very commonly, and that's why lipoid pneumonia is quite common. So in these places, so we should be actually during discharge of a newborn, we should be telling them certain things, and of those, one of these is avoid oil massage, oil installation in the nose till the child is actually, and never do oil installation in the nose. Actually, that's what we should say.
And I don't know whether it happens in Delhi or not. Chitkara, we have that system of where there is ajwain ka seek diya jata hai.
That's not common, but occasionally we do find a family, Orthodox family, which does it. But however, last few years, if I recount, just handful of cases where I suspected lipoid pneumonia because the history was positive. But it is too uncommon to say that instilling oil into the nose is a common practice in a city like Delhi.
So, but yes, there are certain child rearing practices which need to be looked into if one really wants to have a foolproof system of preventing pneumonia. Now let's come to the vaccine aspect and other preventive tools. If you look at this study, the PERCH study, which looked at about nearly 2,000 cases of pneumonia with good controls. And they said 60% of the pneumonia is caused by viruses. 6% is contribution by TB. And then you have your standard pathogens, which all of us are pretty well aware of. With this background, I just want to know, Dr. Chitkara or Dr. Balasubramanian, what are the vaccines which would prevent pneumonia? Which vaccines do you think should be have specific role in prevention of pneumonia? Dr. Bala?
Yeah. In fact, if you ask me which are the vaccines which can prevent pneumonia, I would say all the vaccines, including polio vaccines, will prevent pneumonia. We start with BCG. BCG prevents against tuberculosis. When a child is tuberculosis is likely to be malnourished, is going to develop pneumonia due to something else. Hepatitis B, child may suffer from chronic liver disease and get pneumonia. Polio, child can develop paralysis and pneumonia. And measles, notorious, you don't have to disagree. Chickenpox can cause severe pneumonia, staphylococcal as well as hemorrhagic pneumonia. Right. So all the vaccines, I would say, including HPV. HPV, a woman can get carcinoma cervix and can get secondaries in the lung and then get pneumonia. So all the vaccines which are given can prevent pneumonia, but the priority are for, I would say, measles, number one, I would say, because measles is a number one killer with the pneumonia as a comorbid condition. Then there is no doubt that your conjugate pneumococcal vaccine is extremely effective. Mind you, I'm using cautious words. It's extremely effective in reducing invasive pneumococcal disease. When you talk about pneumonia, you have to understand, by definition, a pneumonia which causes empyema and a pneumonia where there is bacteremia, that is only included in invasive pneumococcal disease. A garden variety consolidation due to pneumococcal pneumonia, if there is no bacteremia, there is no empyema, if you are not getting blood culture positivity or it's not bacteremic pneumonia, it's not grouped under invasive pneumococcal disease. So all the conjugate vaccines are extremely effective in preventing invasive pneumococcal disease. But when it comes to pneumonia, they are not so much effective. But then, by preventing invasive pneumococcal disease, by giving pneumococcal vaccination to infants and young children, you also improve the herd immunity. In fact, US studies have shown it even decreases morbidity due to adult pneumonia. In fact, infant families in whom pneumococcal vaccine is given, the incidence of adults having pneumonia in the community had come down. So indirect effect. In addition, if you look at the direct benefit of the conjugate vaccines on prevention of pneumonia, for reasons poorly understood in African studies as well as in studies in the developed world, have shown reduction in all-cause pneumonia. In fact, even pneumonia due to H influenza, pneumonia due to viruses, the incidence had come down after introduction of pneumococcal vaccine. There is no explanation in the literature, but it's a scientific fact.
Okay, Dr. Bala, having talked about your measles containing vaccine and pneumococcal vaccine, let me come to Dr. Chitkara. We have Hib vaccine introduced in the National Immunization Program. Has that really had a good impact on pneumonia caused by Hib? How important is non-typable Hib as cause of pneumonia? And how effective is Hib vaccine to prevent, as Dr. Bala said, mucosal pneumonia?
See, if you go back to studies on pneumonias, respiratory illnesses, especially in the 19s, you will find some evidence as far as Hib infection is concerned. I think last 10 years when Hib has caught up even in India, and last about 5 years or so when it has caught up even in the national immunization program, we seldom talk about Hib infections. Earlier also, Hib infections were not very prominent. The reason invariably given, and especially by some I would say, anti-vaxxers against the Hib vaccine in India was that since we have a kind of a colonization by Hib very early, even anti-HIs, probably somehow our children are protected against Hib pneumonias as well as epiglottitis, which is seldom seen, that Hib epiglottitis, which is typically described. But still, I believe a severe pneumonia in younger infants, Hib should be a sizable bug, which has been kind of dispensed with ever since our Hib became almost a universal immunization. And our immunization has now, anything between 70 to 90%, depending upon the states where the health infrastructure is. So Hib is important. I am talking of capsulated HIB. When you say anti-HI, I think personally, and going by the literature also, anti-HI has been only reported whenever there was a kind of an introduction of a conjugate vaccines or particular conjugate vaccines with an adjuvant which was anti-HI, that anti-HI came into focus. But I think anti-HI, be it otitis media, be it pneumonia, is more of a bystander which has been picked up incidentally rather than being an actual pathogen. I may be wrong, but yes, in immunocompromised, in very preemies and others, I don't have data for infants and preemies, but yes, in immunocompromised, anti-HI, like many other kind of an opportunistic organism which are normally commensals but cause a significant disease, could be an important pathogen. But for us in this forum, anti-HI as a significant respiratory pathogen is probably more of stretching it beyond imagination rather than being the actual cause of pneumonia in the children under 5, which we see in this country.
Okay, so pneumococcal vaccine, measles containing vaccine, Hib vaccine. Let me come back to my pulmonologist friend. Pallab, what is the role of influenza vaccine and pertussis in prevention of pneumonia? How important are they?
Definitely, as Dr. Bala said, all the vaccines are important. But pertussis, there are two things. One is giving the vaccine before birth. So giving the vaccine to all pregnant ladies during each episode of pregnancy is extremely important, so that you have, and if it is possible, to vaccinate the others in the family so that you have a cocooning of the child when the child is born. So that is important, because if this newborn develops pertussis, then it is bad. The other thing is that we need to continue to give boosters to these children of pertussis vaccine, because what has been found is pertussis is a disease which is quite prevalent but is not very well diagnosed. So we do not do PCRs, we do not diagnose, and we have a lot of adolescents who go on coughing for a long time, and they may be taking antibiotics here and there, but it's probably a pertussis which is not diagnosed. So pertussis is quite prevalent in our country and in the West also, but it is important to give vaccines to these children at regular intervals, so that this boosting continues even at a later age. It's irrespective whether they take a wholesale vaccine or a Asilder vaccine. It is both of them, the immunity is going to wane, particularly for the pertussis component.
And what about influenza?
About the influenza and the influenza vaccine, the flu shots. Yes, the flu shots, yes, we have to give it, particularly to those children who are prone. So there are immunocompromised children, we need to give the influenza vaccine. We need to give influenza vaccine to all the kids below 5 years of age. So starting off from 6 months of age, and now it's only the 0.5 ml that is given to all kids below 5 years of age. And we need to give influenza vaccine to all the elderly. So above 55 years of age, particularly in our country, we would recommend to give influenza vaccine and a yearly shot in the elderly patients and anybody above 8 years of age. Now, this is extremely important. This age group between above the age of 5 years and till the age of 50 years is not really written for normal patients. and we may not give to normal immunocompetent children. But I think if the parents want, and with a one-to-one discussion with the parents, we can go on giving this influenza vaccine even to older kids. There is no harm in it at all.
Fine. So with ample evidence that viruses are an important cause of pneumonia, we have influenza vaccine which is available to us, which should be used. And I'm sure all of us are pretty well aware that influenza vaccine also brings down pneumococcal pneumonia, because influenza sets the ground for pneumococcus to secondly infect the respiratory tract. Then we have very soon, let us hope that our RSV vaccine is made available, and we could even prevent that component of viral pneumonia. Now, let me come to this case. This was a mother who brought her 2-year-old child to my clinic, and he was diagnosed to have right upper pneumonia. And the mother was very furious, said, "Doctor, my child was administered the pneumonia vaccine, and he had taken all 3 doses. And why did he get pneumonia?" So how do you counsel such mother in practice? Dr. Balasubramaniam, what should I have told this mother? She asked me, why did her child get pneumonia? And was it because of the booster which was not given? Because she had not given the booster dose to her child. What are your comments on this? You have already talked about the limited efficacy of pneumococcal vaccine in preventing mucosal pneumonia. How do you explain to the parents?
Yeah, it's very easy to talk to her. I would tell the mother, your child has pneumonia. We don't know what is the organism. In fact, I suppose I'm not going to get the bug in this child. I don't know, fever, breathlessness. Even if I do blood culture, only 10% is going to be positive. And, urinary antigen is useless for diagnosis. I don't think I will do bronchoalveolar lavage to get a pneumococcus from this child and do a biofire or PCR to find out whether there is pneumococcus. And I may not get the bug at all. That's number one. And you never know whether it is pneumococcus or not. Of course, pneumococcus is the commonest organism. I would tell her that whatever vaccines that we give, they only prevent effectively invasive pneumococcal disease. And pneumonia with, as I said earlier, pneumonia without bacteremia or empyema, the efficacy is not as good as for invasive pneumococcal disease. And of course, like any other vaccine, no vaccine is 100% effective. And I would tell her that it is not likely to be because of not taking the booster, because 3 doses, in fact, studies have shown there are the hypothesis saying that if you give 1 dose of PCV to all under 5 children and achieve 80% immunization coverage, that should be as good as giving 3 doses to 50% of the population. There are postulates. So 3 doses, 2 + 1, 3 doses, that is not the cause for failure. Last, I would say this may not be pneumococcal at all. This may be some other bug. And of course, I would look into other predisposing conditions in this child for this pneumonia. For example, if the child, 2-year-old, is weighing 7 kg, is HIV positive, is immunodeficient, I won't blame the vaccine. I would blame the host. Or the father is smoking.
So you look at other important
other factors which triggered the pneumonia and remove the feeling of guilt in the mother for not giving the vaccine. At the same time, I should tell her, please follow the vaccination schedule appropriately.
Okay. Dr. Chitkara, India is #1 contributor to under 5 pneumonia killers. And it is a very heartening news that in the NIP, pneumococcal conjugate vaccine was introduced about 2 years ago. Which is the PCV which is used in NIP, and what is the schedule that is used?
Well, starting with the answer to your previous question, I would always tell them that after having PCV vaccine, if you think you are wearing an helmet and you stand with your eyes closed on the road, that doesn't protect you from a significant injury. So you may have a partial protection if you kind of meet with an accident. Coming to your specific second question is, See, use of a vaccine which is available in an NIP depends on a lot more factors apart from the bugs it prevents against, that it is very difficult to comment. Well, when it comes to a scientific answer, I would always see which vaccine, even if it is, let's say, 7 valent, 10 valent, 13 valent, or a 20 valent, what are the kind of serotypes amongst the 90 or 94 serotypes which are relevant for my community, my geographic area, or my country. So that decides on what vaccination I choose. I may have a little trade-off when it comes to a pricing because it is a bulk consumption. So even a difference of few paise or a few rupee may make millions or billions for me. So therefore, the consideration is one, what are the bugs I am covering? That depends on what is the prevalence of the serotypes in our country, how much protection is it offering, and how much money do I spend or save when I protect anything between, let's say, 65 to 70%.
Okay,
So
now we are well aware that both these vaccines, 10 and 13 valent, cover more than 70% of the
yeah,
serotypes.
so 70, 75,
And with
whatever
Gavi
percentages you may give.
Gavi funding in those 3 or 4 districts, we have introduced PCV 13 in the National Mission Program with 2+1 schedule, 6 weeks, 14 weeks, and the booster at 9 months of age. How effective is going to be the schedule?
So as Dr. Bala mentioned it very clearly, when I think of a universal immunization in my national immunization program, I have to do the best within the available resources. And 2+1 is a very affordable, very good for a national immunization program. Till the time, see, PCV is only in a few states, gradually to be expanded. When I am sitting in a clinic and I am thinking of individual protection, it has to be 3+1. When I consider of a community projects or a population projects or a centrally or a state sponsored project, then I can have wonders even with the 2+1.
Okay, fine, Chitkara. We are running short of time. I want your quick comment on the efficacy in terms with respect to prevention of pneumonia of these two vaccines, PCV10 and PCV13.
Okay. When you talk of clinical pneumonia, it is just about 5 to 10%. When I talk of a radiological pneumonia with all other kind of a corroborative evidence of an infection, maybe probably a raised CRB, if I am lucky to get it under raised counts and a clinical presentation, I would rate it anything between 30 to 35%. If I take off a culture positive pneumonia, which is about 5% of all pneumonias, probably I would be preventing anything between 70 to 80%, depending on what serotypes are prevalent. So it depends on the endpoint you define. The tighter the endpoint, the efficacy would be more. The looser the endpoint, a kind of a relaxed, you will have a lesser efficacy, which Dr. Bala clearly mentioned. However, it defies any logic to say all cause mortality. But yes, staying safe, staying healthy with all the vaccines, I am sure all cause mortality would be affected by any of the vaccines which were listed earlier by Dr. Bala, including HPV.
Your point well taken. Dr. Bala, my specific question of the two, PCV10, PCV13, with respect to pneumonia prevention, are they equal?
You are asking a very, very, very interesting question. If you look at the pneumococcus history, we have not still got the best of pneumococcal vaccines today. In fact, if you take the story that emanated in UK, once they started using pneumococcal vaccine, there were more cases of parapneumonic effusion due to non-vaccine serotypes. Parents were even angry. So we have not found the perfect vaccine. Between 10 and 13, currently, definitely, because it contains 13 strains, PCV13 it definitely covers more strains than PCV10. And PCV13 is definitely superior to PCV7. So there is no doubt if you cover more strains, the efficacy is likely to be more. But if you ask me what is the difference between 13 and 10 in terms of the percentage, it's hardly 5 to 10%.
Well, but better GMCs, especially for mucosal type of disease, the PCV13 would score over PCV10. Okay, for want of time, I'll quickly move ahead. And as you all said that we need to look into the other aspects also. A child who is predisposed to recurrent pneumonia, if there is a left to right shunt, malnutrition, if there is a refluxing disease, submucous cleft, which is very often missed, immunodeficiency, HIV, so on and so forth. And we have touched upon tuberculosis, how important it is to make a diagnosis, and obviously contact tracing and offering isoniazid prophylaxis is also equally important to prevent the spread of the disease. And I'm sure Pallab must have come across cases of persistent pneumonia where a foreign body has been missed. Now, for want of time, I would touch upon two important aspects. We have fever, cough, rapid breathing. Some children have clear pneumonia, clinical pneumonia. Some can be fit well into the label of asthma. Some have wheeze-associated virus. And there are few children who are clear-cut bronchiolitis. But there is a big chunk of gray where you have, child presenting with acute wheeze, few crepitations, plus minus fever. And I'm sure all of us must be coming across such cases, especially when you have a lot of air pollution, winter weathers, and if there is a child who has an allergic tendency to, so to say. What do you call this? Is this pneumonia? And Pallab, do you need antibiotics to treat such patients? What do you label them as?
It depends, like what is the duration. So if you have an acute wheeze with a few crepitations, then I will not consider this as pneumonia at all. So this is probably one of the episodic viral wheezes, or maybe a multi-trigger child asthmatic who's having this problem, and they will not need antibiotics at this current junction. However, if you have a child who's going on having for a long time with few crackles here and there spread all over the chest and wheeze, then it could be interstitial pneumonia. So that again comes under a different category altogether that we are not discussing today. So acute wheeze, few crepitations, it still is, and crepitations, we should remember, is not a hallmark of pneumonia. It can very well seen in children with asthma and viral wheeze. So it is just the crackling and the opening of the airways which can lead to these crepitations. So we need not give antibiotics to these children.
Chitkar, I'm sure you also must be seeing a lot of such children who come into this gray zone and which are not clearly fitting into any of these four categories. What do you call them? How do you treat them?
See, I am troubled by this. I am troubled by this particular gray area. I have lot of children. But see, I at my age probably have gone through, those earlier training of something like a bigger and a middle airway disease, which we refer to as acute bronchitis, which my respiratory colleagues would not believe. And I'm sure Bala, my contemporary, would probably, we have grown up through this acute bronchitis or a bacterial bronchitis or a persistent kind of a bronchitis. These were the terms which were earlier used, which everything is now grouped by my respiratory colleagues as everything is VAW. So even that Walry thing has gone, which literally a little probably better described these conditions. Though majority would be viral, some of them could be bacterial. So I still believe some of these children with chest signs, no radiological evidence, yet running high fever, looking sick, I cannot qualify as pneumonia radiologically. I can qualify as pneumonia going by the WHO definition. I cannot treat as antibiotic with antibiotics because my respiratory colleagues tell me it is VAW, or look for kind of an atopy or those wheezers. When I find there is no family history, there is no evidence of an atopy in these children, there is no evidence of a immunological deficit, what do I do with them? So therefore, I still believe these are diseases which exist, which have escaped our discussions in various forums and probably should be attended to.
So they also contribute as a part
Yes,
of
a significant chunk, I would say, in a polluted environmental factor.
Okay, okay. Now, for want of time, I would, I mean, if we were in a physical conference, I'm sure Jaideep would come and, yes, off the stage. I would just quickly want each one of you to, give your closing remarks on this importance of pneumonia and prevention of pneumonia. And the slogan is "Stop pneumonia, every breath counts." Starting with Pallab. 1 minute, your closing remarks.
The closing remark would be one is encourage breastfeeding at the time of delivery, encourage immunizations at the time of delivery, talk to parents about the mothers. That's the time when they are most receptive and they'll listen to what we say. And tell them to stop smoking, particularly the fathers, and instill in this fear of smoking, because even if asthma, atopy, pneumonia cannot be prevented, if one person we can, by our discussion, we can make them stop smoking, then that will be a gain that we have done. So that's a.
Dr. Bala?
Yeah. Two things. One, I would look at stopping pneumonia three ways. I will do primary prevention, secondary prevention, and tertiary prevention. Primary prevention, whatever Pallab said, including vaccination, I would do. Secondary prevention, I would diagnose appropriately, I would treat appropriately, and in fact, I would add to the wheeze discussion. Whenever there is a wheeze, my pen will routinely struggle to write an antibiotic for my child. 3, tertiary prevention. If a child suffers from pneumonia and suffers from sequelae, or if a child is prone for pneumonia, that child I will rehabilitate appropriately and look at tertiary prevention. That's my message for the day.
Very well said. Dr. Chitkara.
So I think the message I want to give is don't go overboard following the guidelines by different chapters in kind of a literal meaning or reading between the lines. Assess individual child and treat them, whether avoid antibiotic abuse, yet at the same time, like Bala said, secondary prevention is an important component of respiratory diseases. It is better earlier than late, at the same time remembering AMR.
Well, very well said. And in our huge country with so much of inequity and poor access to healthcare, unfortunate children still do not reach the healthcare facility. They don't get antibiotics. Less than 40% of children get the antibiotic, which is so important for prevention and treatment of pneumonia. We have seen the immunization coverage, which needs to be scaled up. We have Mission Indradhanush and other activities. IAP members and IAP have been very strong advocates of immunization, and I'm sure with our concentrated efforts, we would see that the pneumonia and the pneumonia morbidity and mortality comes down in our country as well. So it was, I mean, I couldn't have asked for a better panel than this. It was an unplanned, it was not a doctored dialogue. There were a few questions which came to my mind while we were chatting, and I couldn't have asked for a better panel of experts than Dr. Pallab, Bala, and Chitkara. With this, I would close here, and I would thank Dr. Jaideep Chowdhury and the infectious disease chapter of IAP for putting up such a wonderful show on the eve of World Pneumonia Day. And let's remember, let us stop pneumonia. Every breath counts. Thank you so much.
Thank you, sir. Thank you very much. I have taken the place of the Dr. Jaideep because he had to leave for some family emergency.
Yeah.
So thank you very much. We couldn't have asked for a better panel than yours, sir. So that is the thing, and a better moderator than yours. So thank you very much, Dr. Yavale, for the excellent moderation, all the panelists and all the speakers, Dr. Bala, Dr. Chitkara, Dr. Pallab, for making this a very successful event. I also thank all the participants for their excellent contribution, attending and making it successful. I also thank the Pfizer for giving the academic support to conduct this program. Thank you very much. Thank you, one and all.
Thank you, Baldev bhai.
Thank you.
Bye.
Bye-bye.
Bye.
Thank you.